Welcome to the Room Now podcast for November the 3rd, 2023. Hi, I'm Jack Cush with Room Now. I want to thank you for following Room Now during this past month, where our campaign on Make Room for PMR was a tremendous success. I want you to know, since you're a podcast listener, that we have a bunch of podcasts that we posted from this campaign that you will find on the same podcast channel. That would include 3 different podcasts of QD clinics, cases of PMR. There's 3 different ones, each with about 3 cases. Cases from myself, Doctors Mackey, Satui, and Lou. You'll also find a 9 mini lecture series on the diagnosis of PMR. It's about a 1-hour listen. I think you'll find that really, really interesting. We also have 2 other podcasts, one on challenges in PMR, and that would include when to image and a number of other topics, including steroid tapering. And the last one, Mythbusters in PMR. 3 different addresses where Dr. David Liu asks the PMR experts about myths regarding PMR, including myths regarding do you need a high sed rate in CRP? Can it only be PMR if it has proximal soreness? And can it be PMR if the response isn't quite as dramatic or as fast as you might expect? I think you'll find those interesting listens as you go forward. But let's get into this week and what we've put on the website, a few nice reports. One about late onset RA. I think it's something we don't talk a lot about. And this article from Arthritis and Rheumatology, actually it's the sister journal ACNR, where they talked about late onset RA, patients who have the onset of RA over the age of 65, and how they get treated. This is a really large study looking at over 3,300 patients who have a mean age at onset of 77 years. And despite everybody's recommendation that newly diagnosed RA should be treated aggressively, only 29% of these patients receive DMARD therapy. What? Really? This has been seen over and over again. It's even worse in the elderly who have comorbidities. And the bottom line is, I don't change how I treat patients if they're 75, 55, or 35. There is no evidence to suggest that they're going to do worse. The only evidence suggests they'll do worse is because they're older, which actually means that their mortality rates are higher, but that's only because they're older and because they may have comorbidities. It's got nothing to do with their therapy. They will suffer just as much and need to be treated just as aggressively as everybody else, and that's the point of that paper. Another study that looked at remission and its association with X-ray progression. Now, you would think this is a no-brainer, right? That if you're in remission, you're going to have less X-ray progression. And that's, in fact, what they found in this ESPOIR early RA cohort of 256 patients followed for 10 years. They showed that when they categorized patients according to SDI remission, that was sustained, or sustained low disease activity state versus sustained moderate or high disease activity, yes, there was significantly less X-ray progression when you were in sustained SDI remission. And that's sort of a no-brainer. The number was something like only 4 sharp units over 10 years, whereas the sustained LDA was 15 sharp units, and the moderate to high disease was at 21 sharp units over that period of time. So in this analysis, they showed that people who had sustained remission were going to be younger with lower HAQ scores, lower baseline sharp scores, radiographic scores, and less need for glucocorticoids, DMARDs, and biologic DMARDs. Basically, if you have milder disease, you have a greater chance of remission. A no-brainer. But this is important when it comes to prognostication. And I don't think it changes how you treat. Treat everybody aggressive until you get to remission. You're just going to get there more easily in those who have that profile. Younger, lower HAQ, less damage to start with. They're going to respond better, and they're going to do better on down the line. When they're not in that profile, you even worry more than you're already worrying. An analysis of TNF inhibitor tapering in axial SpA patients was another no-brainer report. I put it up because it's something I often rant about, and that is don't be weaning drugs that are working. These diseases are too hard to treat. Why would you want to take them off therapy just because they're in remission for 6 months? Do you think rheumatoid arthritis or axial spondyloarthritis goes away or lupus goes away? Hell, we know that even diseases like, GPA, they don't really go away. Same thing for, I think, GCA. There's a lot of evidence suggests that there is sustained low-grade disease. Anyway, let's talk about these SpA patients. 108 patients. And what they did was they gradually weaned their TNF inhibitor. So if you were in remission, they put you on 2/3 of the dose. And guess what? 27% flared. When they dropped you to 1/2 the dose, another 20% flared. When they dropped you to 1/3 the dose, another 27% flared. And by the time you discontinued drug in everyone over a 2-year period, 99% of people flared. 106 out of 108 patients. Why would you do this? I don't do this. I know patients are going to want to do it, and it's you're going to either go along with that or not. The question is, are there consequences to that? And in some there are. There are radiographic consequences, and inflammation has a detrimental downstream effect in everyone. So, talking about large data, I think one of the best data sets that we have out there is the German rabbit registry. It's been so productive over the years. In a report in RMD Open this week, they reported their experience in looking at RA patients on JAK inhibitors versus other biologics and DMARDs, and were MACE events more frequent? This is obviously a response to the oral surveillance data and whatnot. So in their study, they have 14,000 people on treatment. They have 21,000 patient years of follow-up. They noticed 154 MACE events, and the incidence rates were the same across the board: 0.68 for JAK, 0.62 for TNFs, 0.76 for biologic DMARDs, 0.95 for conventional DMARDs. Those are not statistically significant from each other. Those rates were increased if you looked at only RA patients who had cardiovascular disease as a background. They increased by as much as 60 to 100% as far as the incidence rates. Interestingly, in this study, hazard ratios were not increased in people over age 65 who had cardiovascular history or smokers, which was the profile that predicted cardiovascular events and MACE events in the oral surveillance study, meaning that you didn't worry about all the high-risk patients who went in over the age of 55. You worried about over age 65 who were smokers, who had a prior history of MI. They didn't find it in their study. Wait a second. The oral surveillance was a prospective, well-designed, appropriately powered study meant to answer this question. The Rabbit Registry is a retrospective look at a large data set. It's not even close as far as the power you get and the interpretability you get. The only thing you can do with a registry-based large cohort retrospective look that's modeled to look something like the oral surveillance study is you can get a signal that is hypothesis generating. It is not proof of principle. You want proof of principle, do the study that Pfizer did called Oral Surveillance, the 1133 study. Everyone else is just pretending. Again, I give them kudos for doing this work and raising this discussion, but I don't know that it really helps me in deciding how to treat my patients. Two big announcements this week from the FDA. The FDA approved secukinumab for use in adults with moderate to severe hidradenitis suppurativa, making it the second biologic to be approved for hidradenitis suppurativa, joining adalimumab. The recommended dose for secukinumab is 300 milligrams sub-Q at week 0, 1, 2, 3, 4, and then every 4 weeks thereafter. If they're not responding, you can go up higher. You can look at the package insert. Interesting, nice thing. I actually see a fair number of hidradenitis suppurativa patients, with or without musculoskeletal complaints. And no, I don't think it's part of the spondyloarthritis spectrum. FDA has also approved this week abatacept for use in juvenile psoriatic arthritis. That's kids age 2 to 17. And again, this now is one of now many indications for abatacept. The approval is really based on the prior approval of abatacept in polyarticular JIA and observational data since that approval. This week I was in a meeting and I had a bit of a debate with one of my friends about what is the risk of hepatitis reactivation in patients who are hepatitis B, core antibody positive, hepatitis B surface antigen negative. So those are resolved infections. The chance of reactivation that I quoted to my colleague, based on my analysis of over 200 to 300 patients, all small case series, was the risk was 1% to 2%. In this week, another meta-analysis appears, 2,252 patients, that same profile, B surface antigen negative, meaning no active infection, and core antibody positive, and the risk was 2%. It was higher if you were on rituximab, it was 9%, and abatacept, 6%. The recommendation is that if you have that profile, you watch the patients. I would use pretty much all of my biologics and DMARDs and just watch them and worry. I'd be checking LFTs. If I didn't know what I was doing, I would get a consultation with a hepatologist. If, however, it's an RA patient or a patient going on rituximab with that profile, then that's a much higher risk of reactivation. And yes, they should probably be on prophylactic antiviral therapy like atanavirir or something like that, and also see a hepatologist. So again, I think that those rules are pretty. What's the role of hepatitis of being surface antibody positive or negative? If you're surface antibody positive, you're likely to be immune and more protected. If you're surface antibody negative, you're not immune and you're more vulnerable to reactivation. That's the data from a lot of different studies. The NORD-DMARD registry and Dan Alataha's group looked at definitions for an RA flare. I think it's a big issue no one's paying attention to. Flares are damaging. Inflammation's damaging, right? And we see flares all the time, and we just, 20 milligrams of prednisone, 5 days, 10 days, whatever. I think we need to have more studies about flares and flare management and consequences of flares. They've done the first step, and that is in their analysis of the NORD-DMARD registry and the RA cohort in Vienna. They found that a definition of an RA flare was an increase in SDI of 4.7 or an increase in CDI of 4.5. And those flare definitions did have correlations with functional and radiographic outcomes. So we're on our way maybe to having better studies regarding flare. A nice report in JAMA this week talks about knee pain. We all talked about it, but how much do you know? What number of patients going to the primary care doctor for any reason are going in for knee pain? Well, this study says 5% of all PCP visits are for knee pain. And they kind of review the three most common causes, knee OA, patellofemoral OA, and meniscal tears. And the stats I threw up was 654 million people worldwide have knee OA, and it affects people over the age of 45. Patellofemoral OA is actually in younger people, less than age 40, and they usually have anterior knee pain, especially with squatting. And then meniscal tears are quite common, up to 12% of adults under the age of 40. It's diagnosed by a McMurray test and joint line tenderness. So look for that in your patients who have knee pain. Two big articles we wrote about this week was a compilation article, 2 reports about the efficacy of the Shingrix vaccine, the the herpes zoster subunit adjuvant vaccine. That one study from, I believe it's Sweden, looked at 82 RA patients on JAK inhibitors versus 51 controls. They got 2 doses of Shingrix, and they showed that both patients and controls who received the Shingrix vaccine had significant increases, 4-fold increases in their antibody titers. But that 4-fold increase was achieved by almost 81% of RA patients, but 98% of controls. So it is less than RA, right? And that's something we do know. That we also know that overall, the post-vaccination antibody levels were lower in RA than non-RA people, and that RA patients that were on JAK inhibitors, the seroconversion numbers were less if they were also on methotrexate. Again, the two drugs that really kill vaccine responses is number one, methotrexate, number two, rituximab. So the point here of these studies, and the second study was from Spain, where they actually showed less seroconversion. Here, no controls, 49 patients with immune diseases taking a variety of different JAK inhibitors. They only showed that fourfold increase in titers in 39% of people. And that's sort of surprising. These results were, in this study, unrelated to activity, because 63% of those people were in remission, or background DMARD use, 33% were on DMARDs, and only a minority were on methotrexate, or none were on rituximab. But both these reports say that, one, you can get seroconversion if you're an immune patient, an RA patient, and you're taking a JAK inhibitor. You can get seroconversion. Number two, it is variable, and there may be a lot of factors in play, and it's maybe not the JAK inhibitor you're worried about in that person, but you're worried about methotrexate or drugs that will impair vaccine responsiveness. The question is there a downside? There's an adjuvant here. That first study in Sweden showed that 6.5% of patients had an increase in their RA disease activity scores. So other studies that have looked at cohorts show a low rate of RA flares. So I think this was probably the highest one I saw. The other report from Spain did not actually report on other major side effect issues. I like this report in JAMA about optimal management of Dacre-Vane's tenosynovitis. We all see a lot of that. In their study, they basically come up with the fact that, yes, steroid injections do work, but they work best if they're done under ultrasound guidance. And then secondly, that steroid injections work best if it's followed up by thumb immobilization for at least 3 to 4 weeks. That's the recommendation of this particular JAMA article. This week we have a number of cases submitted to us on Room Now, Ask Cush Anything. Here's a case or a question from, this is from Dr. Madan Padmajan. Let's see what he has to say.
Hello, Dr. Cush. I'm Dr. Madan Mohan from India. You had a 1-month campaign on methotrexate. One thing which is not clear to me is there any relationship with methotrexate intake and food?
So he's asking, is there any relationship to taking methotrexate and food? He says his professors always taught that methotrexate should be taken on an empty stomach. He sounds a little older like me, not as old as me, and that might have been the recommendations back in the 80s and 90s. So I actually looked this up. Number one, the package insert on methotrexate says that food has been shown to delay absorption and reduce peak levels. A lot of the early reports about methotrexate use in kids with cancers like ALL says that for maximal serum levels, methotrexate should not be given with food. But there are 3 studies I found, 2 from 1992, 1 from 95. There's a few others I need to look at because of the consistency in messaging that say that the bioavailability of low-dose orally administered methotrexate in our patients is not influenced by food. And that's been my opinion. I always told patients take methotrexate with or without food, doesn't really matter to me. And I think that that's really true. And I guess unless you're a kid with cancer, where maybe the levels are maybe even more important because you're using higher doses and max levels are going to be more important. But again, we get fairly low levels with our oral absorption. Interestingly, a few other reports, bioavailability of oral methotrexate is markedly variable individual to individual. And Joel Kremer wrote about this in 2004, where he said food does not affect methotrexate absorption, but he did find one report that said milk may have some inhibitory effects. So I think bottom line is, Madden, that there is no concern here regarding taking your methotrexate with food. Here's another question.
Hello, Dr. Jack. How are you? I have a question that I have a female patient with positive ANA and positive double-strand DNA, but actually I haven't any symptoms. Any suggestion regarding management-wise?
So Mason asked the question about a woman who he's seeing who has a positive ANA DNA, but has no other symptoms. I presume no other symptoms of lupus. And, you know, a lab test does not make a diagnosis. I don't care what your lab test is. You know, if someone showed up in my office with a white count of 44,000, I don't know what your diagnosis is. I just know I'm trying hard to find it. I'm not going to treat the 44,000 until I know what the cause is. I guess the real question for Mason is, why'd you do the ANA and DNA? You know, and I guess if you're ordering batteries to test and getting back batteries without being selective, then this is the problem you get. So no, I wouldn't treat. I think I would consider the other causes for ANA and DNA, and for both those together, the most notorious cause is hepatitis B and hepatitis C. The second most common cause outside the United States might be parasitic infections, where parasites drive tremendous levels of IL-10, which stimulates B cells to go crazy. You know, chronic lung disease, other cancers, other autoimmune diseases can sometimes be found in such patients. But because I found ANA and DNA, doesn't mean I'm going on a crazy, wild, expensive chase for a diagnosis. Again, don't order the test unless you know what you're going to do with the positive result. That's why the advice is always act like a lawyer. We had two other cases submitted online. Dr. Christian Duquet, or Duquette, sorry if I mispronounced that, says in our recent polymyalgia rheumatica Tuesday night rheumatology, asked there was an issue about doing large vessel imaging in PMR. And I think that the answer during that session was you don't do extra imaging, either ultrasound or PET or other MRA even, in PMR, unless you have very atypical cases and you're looking for GCA symptoms. But Christian asked a question, in a case of classic GCA that's proven by biopsy, should you be doing large vessel imaging as part of the initial workup? And the answer is an unequivocal yes. Why? Not because I say so, not because my experts during the PMR campaign said so, because it's an ACR guideline. The ACR guidelines say newly diagnosed PMR should have an initial search for large vessel disease. That can be by MRA, CTA, or ultrasound. You don't need to spend a lot of money on PET scanning. That's part of the initial workup. So the answer is an unequivocal yes. And lastly, Monica Mohan from Lansing, Michigan, sent me an interesting email about her patients who she's had, who said that when they received Paxlovid for COVID, that their RA got better. What's the deal with that? Have I ever seen that or heard of that? And the answer is an unequivocal no. I've never heard it, never seen it. But if you think about it, this is how I might explain it. First off, you don't have to explain it. It's too rare to spend too much time on. But we're going to do so because we're just sitting here talking stuff. And I think that the converse is true here. Meaning, if you get COVID, and you know this, patients who've gotten COVID or patients who've gotten the COVID vaccine have flares of their underlying disease, or what seem to have what looks like new onset disease. And my pedestrian view is that the spike protein is a pathogen-associated molecular patterns activate the innate immune response and the inflammasome, and you can get activation of what you have or what you're predisposed to. And that's why you see cases of what looks like Still's disease, a very inflammasome-driven disorder. The inflammasome is very much involved in RA and lupus and vasculitis, etc. So again, the infection may itself make RA worse, but control of infection and the virus and the spike protein may maybe there's a reverse effect to that. That's my crazy, weak hypothesis. Otherwise, I cannot come up with a mechanism that would explain Dr. Mohan's experience. That's it for this week on the podcast. Hope you enjoyed this. I want you to know next week we're starting our coverage of ACR 2023. It's going to be wild. It's going to be wonderful. Put on your seatbelts, put your tray tables up, put away your laptops, watch what we're going to do, listen to what we're going to do. It's going to specifically make sure you look at our nightly, daily recaps. That's going to be 9 p.m. Eastern, 6 p.m. Pacific time. We're going to have a panel discussion of what was great on Sunday, Monday, Tuesday, Wednesday, all 4 days. Look at those. Follow us on Twitter. Look at our topic panel discussions where the experts in RA get together and discuss what was hot from the meeting on RA. We'll do that for RA, lupus, JAK-TYK inhibitors, spondylitis, and psoriatic arthritis. And there's a whole lot more. But don't worry, if you miss it during the 4 days of ACR, you've got the rest of the year to catch up because we'll be rolling it out for you. And lastly, I want to remind you, registration for Room Now Live is open. It's January 28 and 27 in Dallas, Texas. You can be there. You can be online. It's going to be a great meeting. I'll talk about that in the future. Take care of yourselves. Bye-bye.